Okay, so hi. This is a presentation on Chapman's reflexes. You guys all know me already, so I'm not going to pretend you don't, because I don't have to. So I teach a 6-day course on Chapman's reflexes and their integration through both a biomechanical, actually all three, a biomechanical, a biochemical, and an emotional perspective. And so today is just kind of an overview of what Chapman's reflexes are and how they can be used. And we'll go through a small exercise in order to just kind of play with that concept of them. We're going to look at a little bit of the history of the reflex, just a general concept of what health is. And then we're going to look at what evaluating a patient sounds like or looks like, if Megan doesn't kick the camera to the ground. So if we go back to the beginning, basically, Chapman graduated in Kirksville in 1899. He discovered the reflexes in 1920. He named them, he didn't actually name them after himself. He wasn't that egocentric, which is always kind of fun to know. He called them neuro-lymphatic reflexes because to him, it was integration between the lymphatic drainage and the neurological symptoms. And they had as much of a therapeutic effect as diagnostic potential, right? So yes, they can be therapeutic, but they can also be diagnostic, and I'll show you how to use both. I'll show you how to mostly use them as a diagnosis. I use them potentially much more as a diagnostic tool than I do as a therapeutic tool. His brother-in-law Owens discovered how Chapman used them, and he's the one who made them quite popular. He published the book called Endocrine Interpretation of Chapman's Reflexes, which is kind of the textbook on the matter. How did he discover them? Basically, he went around palpating people in hospital and realized that people who had similar medical conditions had similar sensitive points on the body, right? According to him, the edema was present because of poor lymphatic drainage. Therefore, he called them neuro-lymphatic reflexes. Owens, like I said, was his brother-in-law. He established something called the pelvis adrenal thyroid gland. He believed that the thyroid's incomplete metabolism was what was causing most accumulation of toxins in the body. So basically, if you don't break down something all the way, what's left is a toxin. Which is kind of crazy because it's 1920, right? So if you think about how people's thyroids are operating today versus 1920, to me was always kind of a major discovery to go, okay, this guy in the 20s was having an issue with it. Later on, Kuchera's one of the main researchers on them in modern osteopathy. He demonstrated that there was a reflex with the afference of the organ from a sympathetic afference. So there's a link between the sympathetic nervous system and the afference to the organ directly. So we come back to this whole idea of neuro-lymphatic reflex. George Goodhart, who's the founder of applied kinesiology, integrated the Chapman's reflexes early on in applied kinesiology as both a diagnostic tool again and as a therapeutic tool. He always referred Chapman as the source, and there's some differences between the original Chapman points and the applied kinesiology points. I will give you the ones that I use most, which are mostly the applied kinesiology points, just because they're a little bit simpler, a little bit more straightforward, and they're the ones I use the most. So they're generally the same. There's a couple little variations that you'll see. And then Wally Schmidt did a lot of research also on Chapman's points, and he found that there was a balance between the parasympathetic nervous system and the lymphatic system. So basically kind of going along with Kuchera's idea where for Kuchera was a decrease in sympathetic tone, whereas for Dr. Schmidt, it was an increase in parasympathetic tone. So that parasympathetic sympathetic balance for organ function as far as Chapman's reflexes. But the role of the artery is absolute, but we know that the lymphatic system responds to the nervous system. The nervous system depends on the nutrients of the circulatory system, and the circulatory system responds to the nervous system, and on and on and on and on. These are funny images. So do I call a plumber or an electrician? The constant battle between osteopaths and chiropractors, and we're just both looking at the same cylinder, just not through the same lens, right? Which is always, I like this one. Look at me, I'm white, black, and Asian, and everyone likes me. So can't we all just get along? And this is a great Andrew Taylor Still quote: "To any person born above the condition of an idiot who has familiarized himself with anatomy in working with the machinery of life, knows that all disease are mere effects, and the cause being a partial or complete failure of the nerve to properly conduct the fluids of life. So again, artery, nerve, lymphatics, we're all coming back to this whole system, right? And then as far as the complexity model, if we want to integrate something, we have to understand that we must be at least as complex as our patients' bodies. So we have to be able to understand the different inputs into the system and how they correlate to each other in order to get any information back from it, in order to be able to treat it appropriately. And even according to Owens in the early 1900s, 80% of the problems he saw were due to what individuals were consuming. So again, not necessarily, there's this whole idea of context versus content in osteopathy. So are we looking at working on the content, the inner portion, or the context, whatever's outside it? So are we looking at structure versus function, function versus structure? Both are kind of balanced. But in the 80s, Owens thought it was a lot of function. Again, we just want to be aware that what we're evaluating when we're evaluating Chapman's reflexes is not a sick versus a healthy. We're looking at somebody on a continuum. So you're probably not completely black, but not as white as you should be, right? Right. I love it. And so this is the way I explain it more and more to people these days is it's like you're doing an exam, right? And the medical doctors, what they're going to do is if you're failing the exam, you got 50%, that means you actually have a disease. You're sick. You need to be treated. Now, if you got 61% on an exam, you pass, right? You didn't fail the course. So the medical doctor goes, you're not sick. So you get to go home. Now, if you had gotten 95% on that exam, you probably understood the subject a lot better than if you got 61%. So my goal is, where are you? Are you at 95% health? Are you at 60% health? Are you at 61% health? Or are you at 50% health? If you're at 50, go see a medical doctor. They do a great job with that. And that's really important. So the classic question is, where do we start? And we always want to be able to differentiate between our goals and our patient's goals. So the important thing is to realize that our viscera can be involved in pain patterns. We saw this today between the links between the viscerosomatic and somatovisceral implications of pain, right? And we know that all organs have a viscerosomatic pain distribution along the body. This one's the one I use all the time because everyone understands it, with the heart and the left arm and the left chest, right? Everyone knows if someone's grabbing their left chest and has tingling down their left arm, call 911 kind of thing. Well, your heart's not your only organ that has that function. Everyone has it according to kind of that dermatomal distribution with the spine. So we have to understand that maybe what our patients are experiencing are actually from an organ malfunctioning more than they are from an actual musculoskeletal condition. Just different versions of the same thing, the explanation of that. And then we have different research papers indicating the possibility of viscerosomatic pain and what it comes from, understanding them, thoracolumbar pain with cholecystitis, incontinence with back pain, somatosensory changes with acute inflammation of the appendix, back pain in women with gastrointestinal problems. I like the mood. I like the mood that we've set, Eric. I feel like everyone should snap at the end. Like no one should really clap. Everyone should just kind of snap their fingers. And then, effects of a colon cleanse on anxiety and low back pain. So we know basically that treating viscera will have an impact on low back pain and musculoskeletal pain, right? Organs attached to psoas. And we saw this slide actually today on the metameric levels of the spinal column. Plus all muscles are related to organs according to applied kinesiology. So our organs might be the priority. So if we look at them, our reflexes give us an opportunity, give us a window into that system, into that information. So remember, our lymphatic system is basically the 30% of the blood that doesn't come back through the venous system. We have our arterial blood it gets switched, right? We go through our milieu, most of it gets reabsorbed and goes to the venous system. Everything else goes back to the lymphatic system. There's different ganglia throughout the body. The organization of this is somewhat organized. This is a circulation that we don't see very much, right? It's not something that we spend a lot of time on. We tend to forget about it. It's quite important because it does kind of dictate 30% of what's coming back, and can have a huge role on inflammation and all those things, all those processes in the body. We even know now that the brain has a lymphatic system. That was a huge discovery in, say, 2014, Nature, something I would have to say. And so if we go to the reflexes, the actual reflex points, we have them for all our different organs, right? So neuro-lymphatic anterior for eyes and ears is the bicipital groove. The posterior one is the suboccipital. I gave you guys the metameric level. The innervation for eyes and ears is huge, and then also the vascularization. We're going to focus mostly on the neuro-lymphatic points just because those are the most interesting and what we're mentioning, right? Brain and cerebellum, we're looking at the coracoid process. Lamina of C1 is actually really big too. The sinuses, 3.5 inches lateral to the sternum on the superior part of the second rib. The thyroid is the second intercostal space near the sternum. The heart, second intercostal space near the sternum. The lungs, the third and fourth intercostal space. The thymus is the only, right? Just notice those. You'll see that those are indicated in the general diagram at the end. The liver, we're looking at 5th and 6th intercostal space on the right. Gallbladder, 5th and 6th intercostal space on the right, sometimes to the 7th even. Stomach is 6th intercostal space on the left, so the stomach is on the left, just for being clear. Spleen is 7th on the left. Pancreas, 7th on the left. Small intestine is along the costal cartilage, right? On both sides. Chapman divided them in superior, inferior, superior to inferior. I don't use that very much, but he did do that. Large intestine, we're looking mostly at the IT band, basically, right? So this is really a classic, and this is actually pretty funny because everyone has an IT band problem, right? Like, oh, I got, tight IT band, tight IT band. I'm gonna say more than half the time, that's usually just like some sort of dysbiosis and or leaky gut and or something else going on completely that I find. Rectum, we're looking at the lesser trochanter. Kidney, 1 inch lateral and 1 inch superior to the umbilicus, out an inch, up an inch. And then T12, and then adrenals is 1 inch out, 2 inches up. This one I actually use the posterior a lot because it's, I think it's Rogoff sign, which is also this, which is kind of coincides directly with the Chapman's reflex, which is the posterior space between the TPs of T11 and T12. The bladder, we're looking at symphysis pubis, the prostate, symphysis pubis, and also the lateral aspect of the femur. Testicles, symphysis pubis, uterus, symphysis pubis, and IT band, ovary, symphysis pubis. So there is a slight difference between like the more medial aspect of the symphysis pubis to the lateral aspect of the symphysis pubis. Now I have to say that just for general practice, I tend to just understand that symphysis pubis will be some sort of genitourinary issue. And it's very hard for me to say, oh, I'm going to distinguish between the lateral and the medial aspect of it. I find it practically doesn't make all that much sense. And just even if you look at it anatomically, those systems are so close together that it's worth going to investigate them. These are Chapman's actual, I think these are from Owen's actually, his original drawings of what they are. So you can look through them. They're a little bit different. This is the one I use, which you guys will get. The ones that are in red are unilateral. Everything else in blue is bilateral. So this gives us a general idea of what those Chapman's reflexes are. These are the posterior ones. I don't use the posterior ones very much for the simple reason that most of the time when I treat my patients, they're on their back. So I'm having a conversation with them at the same time. Doesn't mean they can't give any use. And again, someone has pain in kind of this area and it's kind of very lymphy and edema. Well, I might just decide to go address that. But the idea being I use more the anterior ones just because they're simpler to use. They're not made to diagnose anything. So this is always what we have to be careful of. And I always give this example to my patients whenever I talk about organs, just as far as a disclaimer. I go, well, the problem seems to be with your liver. Just so we're being clear, it doesn't mean you have liver disease. It just means it's not functioning to 100% of its capacity. That's what that means. And so we want you to function to 100% capacity. Now, what we do know is that, I'll say about that later. Now, I never ever have used this, but it's actually kind of cool just historically, but this was kind of Chapman's algorithm. This is how he did it. He would go from one, and then he would look at what comes next. So restore respiratory and circulatory dynamics. So basically work on the diaphragm. Is there still lymph congestion? Yes. So osteopathic manual treatment to increase lymph flow. Go back down. Is the pelvic thyroid adrenal syndrome present? Yes. Treat the Chapman reflexes for the gonads, the adrenals, and the thyroids. Then he would elimination organs, treat those. Then he would go to the specific problem. So he would have that order in which he would work before he would actually go on to something. The way I'll show you guys today, it's a little bit more fine-tuned to whoever's in front of you, which is kind of neat. These are his sequences for different types of disturbances. They're kind of cool. I've never used them, but just historically, they're interesting to know. And so we can use them for an so these are the treatment basis, but we can actually use them on an evaluation basis also. So they'll be puffy and sensitive if they're active. You'll see what that means because we're going to do that. So the power of these reflexes is they're going to be able to tell us if we're at the right location because of the differences in organ placement. And they're also going to be able to tell us if we're going in the right direction when we're going to start working on organs. And they're also going to be able to tell us if we're done doing what we're doing. And I'll show you guys how that works. And we know that, patients with pneumonia tend to have Chapman reflex points of the lung that are active, which is kind of cool. There's not a billion of these research, but, we'll take the ones we get. Again, different placements of of the ileocecal valve. How are you going to know if you're on the right spot or not? You can easily use Chapman's reflexes in order to validate that. Different shapes of the liver, different shapes of the stomach, different shapes of the kidney. You can use the reflex in order to validate palpation and validate direction. We're just going to workshop it. So we're going to go back to this slide. And then come and lie down. And so you guys are just going to practice this just because I think it's worth practicing and it's kind of cool. Lie the other way just so I don't have to change directions. And we're going to go through palpating the different reflex points. Now, the only issue I have mostly with manual therapists is they don't want to hurt people. The goal is not to hurt somebody. The goal is to get the information. So if it feels puffy and sensitive, make sure that the person on the table feels it because that will give them information back, right? So the bicipital groove, this is eyes, ears. A little bit there. He has a tendency to squint a little bit. Coracoid process, brain cerebellum. 3.5 inches lateral to the sternum is sinuses. Parathyroid is the first intercostal space. Center intercostal space is thyroid and heart. Third and fourth is lung. That one's a little sensitive right there. We've got a little lung on the right, on the third intercostal space. Fifth intercostal space on the right is thymus. If I go a little bit more lateral, I have liver. I have liver. I have liver. So we know there's liver and or gallbladder, right? Those are kind of similar. But so there's actually AK research that's been done. And when you palpate this reflex appropriately, if I hit the same spot, his reaction is going to be the same all the time. Where he'll flex he's same thing, right? Flexes the left leg, flexes the left elbow. The reason that's important is because when it disappears, I want him to know that it's disappeared. Exactly. Then they get nervous, right? So 6th intercostal space on the left is stomach, 7th is spleen, and if I go a little bit more lateral, I'll hit pancreas. I'll usually go one below just to make sure. Costal margin is small intestine, so he's got probably that lower part, and then costal margin on the other side, not so bad. I'll go 1 inch lateral or 1 inch superior is kidneys. 1 inch above that is adrenals. I'll go posterior for the adrenal glands at that T11, T12 junction. Tends to be something there on both sides. And then after that, so when you're going to symphysis pubis, just be aware, because I'm not, going in on this, just, especially in men, but also in females, because, it depends on where everything is. But I'll start at belly button and go with the blade of my hand moving down.
So we don't ask the client to push.
No, I like touching them. So I'll touch medially and laterally. He's got a little something there, nothing major compared to the other parts. And then after that, I'll palpate the IT band for large intestine. Okay?
How much pressure are you using? Like 0 to 10?
Not much.
2?
Yeah. Now, the reason I say that the power of these reflexes and how it gets interesting is that I can take his liver and I can push it in different directions and see if that changes anything. So I'm hoping his liver's on the right? Maybe he's completely dextroverted and he's completely backwards. But if I take his liver and push it, I can feel like I'm allowed to still use palpation, right? I feel like it has to go up and in. And then I can go back to the Chapman reflex point and the pain disappears. Now, if I let go of it, the pain comes back. So I get a double validation where my patient knows that what I'm doing will have an impact in his life. Plus, I know, okay, if I go in that direction, I can release all the ligaments, all the tensions, everything else that I know around that, but I probably should go in that direction. Right? I'm gonna have you guys start with that. Just like a short workshop, just palpate. Did you want to do an exercise or anything, or did you just want me to lecture?
I think lecture. I mean, I think it's good to tie it all in with like a couple exercises for them.
Okay, cool. So what we'll do is I'll lecture, and then after that we'll do an exercise at the end instead. Okay. So this gives us an idea as far as, okay, what direction am I going to go in, right? Because I can palpate his liver and go, okay. And very cool. If I go down and out, it'll probably make the pain worse. So his body will respond negatively. If I think about the right, his small intestine point, I can do the exact same thing. Is I can go grab the root of his mesentery deep in his body, bend your knees, and then I can shift it, and I feel like it needs to go up and to the right, and then I can validate that the pain goes away. So I have an idea of what I'm doing. I know that this hand placement is going to have a good possibility of working versus like his mesentery is not completely shifted the other way, because sometimes we get it wrong. Like, I mean, the reason why you guys do palpation, why Eric does the whole under sonograph, well, is because there's so much variability within that system, but this gives us an input directly into what's going on in the patient, right? And we can just use these as palpation tools to validate what's going on. Is that, I'm just going to keep going from now on. I'm almost done though, so it'll be fine. Chapman's reflex, blah, 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 blah. And then the question that I always tell people is, okay, well, so are you going to treat every viscera in every patient, right? How does that work? Well, it's actually quite easy. Pratiush, you're up again. So the question becomes, so I know that if I move his liver up and towards his left shoulder, it fixes the liver reflex. If I move the root of his mesentery up and towards his right shoulder, it fixes the small intestine reflex. Now, can moving the small intestine have an impact on the liver reflex? So if I take this and I push it up, I can confirm that, okay, I'm still at the right place. Am I affecting the liver? No, I'm not. I'm not going to. It's not going to work. Okay. So what happens if I take the liver and I push it up and towards the other side? See, he gets scared. Like, people will get scared. So that fixes the liver. Does it fix the small intestine? Oh, okay. That's a good start. So if I push the liver up, Does that fix the adrenal one in the back? Yep, it fixes that one too. So already this allows me to go in a priority. I know that I'm going to want to fix the liver first because that's probably what's causing everything else. How does the liver affect small intestine function? Amazingly. How does the liver affect adrenal function? Amazingly, right? Through everything. Now I can use this to treat anything, but it gives me a priority and as far as where I should start in my treatment if I want to use these Chapman's reflexes. You can sit, but you're going to lie back down pretty fast.
That kicks my liver.
Okay, so it basically, on that domino effect, we'll be able to figure out what the first domino is and try to have an impact on that domino in order for it to go down and fix everything else. I'm not going to talk about this. That fix the main organ. So we've talked about that. I just want to go. And then we can also use them in order to determine what type of treatment we actually want to do, right? So are we going to do, so what affects liver function? We'll use Platypus as an example, right? What affects liver function? Vagal tone affects liver function. What affects liver function? What if it's a somatovisceral reflex instead of a viscerosomatic reflex? What if T10 is out of line? And that's going to affect liver function, right? What else do I have here? Cranial treatment, vertebral treatment, vascular treatment. What if it's the vascular treatment? What if what I have to actually do is not treat the viscera, but what I'm doing is freeing up the hepatic artery? So how do I determine which one of these, which treatment modality? And then after that, you could use any treatment modality in order to fix a Chapman's reflex, in order to get input into the nervous system. Anything you do to get input into the nervous system will have an impact on that. Which technique do I use? So what tools do you have at your disposal? Right? It's Maslow who says if the only tool you have is a hammer, every problem is going to look like a nail. So what are you going to use? So just, if I have Pratyush lie down, and so we've already decided, right? We worked on Pratyush, we go, okay, I want to work on his liver first, right? And so then I go, but what else will affect his liver function? If we look directly kind of on that liver circuit, well, we know T10 at a metameric level will work on liver function. So I can go get T10 in the back. Sorry. And I can rotate it one way. Turn it one way. Does that change anything? No. I can turn it the other way. Well,
Rotating or translating?
I'm rotating. That has an impact. So maybe I want to do a left rotation with T10 in order to have an impact. What about, do I think cranial work can probably have an impact? Let's see. Nothing smart, okay? Just this is kind of the dumbed down version of cranial. What happens if I just move his cranium around? That's all I'm doing. It's not a technique. It's not a, I might miss it, just so we're being clear, but it's a general, let's move the cranium around. Does that have an impact? No, not really. If I wanted to know if vascularization would have an impact, I can go and feel for his hepatic artery. And then I can go up, and then I can go in different directions. I can go up towards the shoulder, a little bit. So I'll go up and towards the other shoulder, more. So again, I get a direction, right? So I know to begin with, to start with, okay, so I've got T10 that needs to rotate. I've got to work on his vascular, on his hepatic artery, in some sort of this direction to begin with. And I could even evaluate something like vagal stimulation if I was to have him gargle or sing, or I could even, anything that will stimulate his nervous system will have a chance to impact his Chapman's reflex. right? And then the beauty of it is I get to know if I'm done or not. So how does that work? So let's do the vascular one because I kind of like vascular, you know, role of the artery is absolute. Let's kind of just do that one, right? So we haven't really decided which one's best, but let's just start with that.
Your direction is going towards.
I'm going up and I'm kind of doing a small little over kind of that artery, right? And there you go. I think I'm done. Okay, I think I'm done. I have no clue. I guess I'm not. Is it still the vasculature or do I have to work something else? Let's go get the vasculature again, push it back up. I guess I wasn't done, right? So I get to go back and finish and know when I'm actually done working on the tissue because the patient's nervous system is going to tell me that information. That's the power of Chapman's reflex is I get that direct feedback from the patient on the table. There we go. And now I change directions. I still get palpation. His body brought me down into the right. So I'm going to go down into the right now, just because that's what happened underneath my hands. It doesn't mean that because I use Chapman's reflexes that I become some sort of a robot automatron moron, right? There you go. Good. Now it's gone. Am I done with the vasculature? What happens if I go on it and I pull it down, completely opposite of what I said? I'm not done. It's not over yet. I'm not done with that portion of it. And the great thing is, Pratyush knows I'm not done, and he'll be really happy once I am.
You keep confirming.
I keep confirming. I keep checking. I pulled down, so I up into the left. I pulled down it, and he was fine. And then I pulled down into the right to go the opposite direction, and the pain came back. So I go, okay, I'm not finished yet.
When you go down, it feels very uncomfortable. Yeah, this doesn't.
I'm on the vasculature. I'm on the hepatic artery.
No, I know, but I mean, is his problem that his liver is translated to the?
I don't know yet. Maybe.
Oh, okay.
Maybe. Is it translate? Was it like initially that first treatment was to bring his liver up into the left, right? Now, was that because it freed something up on the artery? I don't know. I just chose to treat the artery first because I'm an osteopath, right? If I was a chiropractor, I would have cracked the crap out of T10. I'd just sidelight him or like rolled him down, just bam. It would have been great. I could have charged double. There we go. Now I come back. I think I'm done. There's no pain initially. Come down, pull down and towards the right. No pain. Up and towards the right. No pain. Up and towards the left. No pain. Good. I think the vasculature's done. Let's go back to treating the liver. So how do I get the information? It used to be up and to the left that would free it up. So what happens if I pull the liver down and to the right? No, he got scared, but that stayed fixed, right? What if I go up and to the right? Nothing. What if I go down and to the right? Nothing. What if I go back to the spine and see if that changes anything? I go to T10 and I rotate it one way, nothing. And I rotate it the other way. Uh-oh. If I rotate it, yeah, that comes back. So I'm going to go pump T10 or adjust T10 or whatever I want to do with it in order, there we go, for that not to show up anymore. There we go. So I'm pushing it back to where it hurt. No more pain. If I want to go even crazier, I'll have my students do this sometimes. Let's have him just activate his sympathetic nervous system. How do I have him activate his sympathetic nervous system? Breathe through your mouth. Just pant through your mouth. Good. He's fine. It's gonna hold until at least like his mom yells at him or something, right? Okay. Thank you, Pratyush. So we can use the reflexes in order to determine what tools we're going to use to treat our patients. and what priority we want to establish within the system. Knowing that resilience is the capacity to prepare for a disturbance, recover from a shock or a stress, as well as adapt and grow from the experience. Meaning, I want to make his body capable of resisting something, whatever that is. And so that's why I brought the liver back towards the direction that should have hurt him. I brought the hepatic artery back down to where he was feeling great pain in order to go, okay, that means my treatment will last longer. There's a chiropractor who I like very much, who's called Tim Francis. And in his classes, he always says, how long does that last? How long does it last, right? And you know, he always jokes and says, as long as it lasts long enough for them to pay you, you're fine. And then we have to understand that the reflexes can actually change for any reason that stimulates your nervous system. So that means, so the way I built the Chapman reflex course is we look at biomechanical reasons why the Chapman's reflexes change, neurological reasons why Chapman's reflexes change, physiological, I'm going to say, yeah, biochemical reasons why Chapman's reflexes change. And so anything, and then emotional reasons why Chapman's reflexes change. So anything that stimulates your nervous system will have an impact directly on neuro-lymphatic reflexes. So I can have, Pratyush, I can find a bunch of stuff that's really tough on the liver and expose Pratyush to that. So if he has amalgam-filled cavities, I can have him grind his teeth and release mercury. If he grew up on a farm, I can have him sniff some Roundup and see what happens there. I don't have him taste the Roundup, I just have him sniff the Roundup, just sort of being clear, right? If, you know, if he hates his mother, I can have him think about his mother and see what happens to those reflex points in order to get that information back and then decide how I'm going to treat it. And you know what? A lot of the time it's in the body. Like, we have to realize that a lot of this stuff happens within our body. So we have that capacity all of a sudden with the reflexes to figure out where it's from, figure out how to treat it and make it better and make sure that it's resolved. The biomechanical reasons are, you know, mostly tension, and then we can have people just change positions. So we'll do this all the time where, you know, what are the difference in the tensions on the feet versus standing to prone, on the viscera versus, you know, side lying to standing to seated? What's the difference on the influx of the nervous system when you're clenching your teeth? Huge impact. So we could do all of those things. How do we evaluate we can evaluate the reflexes standing and see what we're looking at and what's important to manage within that viscerally, but also maybe somatically, right? Maybe standing, the reflex shows up, but the reason is you have a short leg. And then we have to address that component. But we have a really easy way of knowing whether or not that's the issue, in the sense that, okay, just here, we'll do it this way. Stand up. So we treated him supine, right? Let's just go back to liver because that's easy. Okay, so already a little bit, not so much. Not too bad. So what if I wanted to know if it was his feet, right? So roll on the outer edge of your foot, lift your internal arches. Up, 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 more, exaggerate, yeah. Well, that's better. So squeeze your feet down. Well, that's worse, right? So there's something going on through the feet that's causing that to happen. So maybe I want to specify which foot. Keep,
This one?
roll the right foot out and the left foot in. That's not so bad. Roll the right foot in and the left foot out. So that sucks. So maybe I'm going to go work on his right foot a little bit more. I want to confirm, just lift this leg. And that's way worse. So I'm going to go see what's going on that right foot, because I know that's going to have an impact all the way up the chain. So even if it's not visceral, I can use Chapman's reflexes knowing, okay, his liver's probably his weak point. We fixed part of it. We worked on part of it. How long is that going to last? I'm probably going to need to work on that right foot a little bit. Same thing, lie down on your back. We just want to see what happens to the pelvis, right? So let's just see what happens. Let's just move your pelvis this way. Not perfect, not nothing, just a general idea. The pelvis is rotated one way. Not too bad. Rotate your pelvis the other way.
Is it tickles or is it actually pain?
No, it's pain. And now I use sensitivity because some people don't like saying they're in pain, so they'll go, no, that doesn't hurt. I'm just sensitive. I'll go, okay. So there's probably some sort of pelvic and or rotational component in the lumbar spine. We better address that. But we have the input now and the capacity, thank you, to find it using Chapman's reflexes and then treat it appropriately with something that we know is going to have an impact. And this is major to me, where the patient is going to go, oh, okay, this is what he did. And this, I think, is one of the reasons why I like Chapman's reflexes so much, is because chiropractors put you on your side and crack the crap out of your back. So no one comes out of the chiropractor's office going, I wonder what they did, right? No one comes out of chiropractor's office saying that. But if you spend half an hour doing like moving somebody's leg around, working on their SI joint, and then another half hour just doing occiput, well, then maybe they're going to say like, I'm not too sure what they did when people come out of the osteopath's office. But if I show you pain, no pain, pain, no pain, pain, no pain, they have an idea directly that we had an impact on something because we measured something before and after, which is that same model that I taught you guys at the first class, which is that totem model: test, operate, test, exit. And if the last test isn't positive, you come back to the first one. But you could do the Chapman's reflexes standing. You could do them seated because, volume of the glute will have a difference. Pressure on lumbar discs will have a difference. Pelvis will have a difference in seated. We look at, the impact on intervertebral discs in different positions. In a gait position will be huge. I'll do that all the time. Side lying. In some sort of a dural torsion position, you can have somebody and twist them a bunch of different ways and figure out how that impacts Chapman's reflexes. And so you can evaluate the reflexes, you can treat them, you can retreat them, and you can figure out what to use, how to use it, when to use it, and if you're done, which is why I think they're so great and so kind of powerful. That's the end. Merci de m'avoir écouté. Thank you for listening. See you next time. Merci de m'avoir écouté. À la prochaine. Are there any questions? Yes.
Is there something that you're looking for when you take the subjective history that makes you really want to go down this path, or is it part of your just assessment?
Everyone goes through it first time.
Yeah.
So the amount of time it takes me to go through them, like telling you guys all the points, it took me 5 minutes. It takes me 30 seconds or less in clinic. I'll often evaluate them and reevaluate them within the same treatment. But so my initial consult is quite long, and my patients go through two-page questionnaires. So, and that's how I use them, right? So I tell people all the time, I go, it's really kind of a funnel system. So there's the questionnaires first, then there's kind of what they're saying, right? So it's kind of intake form. Then it's Chapman's, and then it's kind of, it's tote. So I'm going like this. That's how that works. But so the time when I won't use them, I'll put it that way, if there is a time when I won't use them, and that'll be like, I walked out, slipped on a bucket of ice, and fell on my pelvis. Okay, I'll just, I'll work on your pelvis then. Like, I use them a lot more in a case where pain has shown up without a particular reason. But beyond that, I use them every patient, every visit. Any other questions? If you guys want to practice them, I can leave just this chart up. If you want to just palpate them and just figure out if you can push a different organ in a different direction, it's kind of fun. Or else, we can be done and you can look at them, and I'll send you this chart easily and you guys can play with it. Yep. Yep.
When you're palpating the organs, when you're taking them to different vectors, you find that it's the most direction of ease that lines up with alleviating the pressure on the Chapman?
No, not necessarily. Not necessarily. I think it'll depend on, to me, a motility versus mobility. If I had to guess, like I haven't documented it, but now that you asked the question and I think about it, my answer would be, if it's a motility issue, I'm going into ease. If it's a mobility issue, I'm going into tension. In the sense that if the liver is stuck to the left because of like coronal ligament and like triangular ligament, stuck to the right, sorry, and like right triangular ligament, and then I know that pushing it to that side is going to feel tense, but they're going to feel relief from it. I have a tendency to more go in that kind of mobility, motion, let's grind at it. Whereas if it kind of feels, okay, no, go into the ease, then I'll have more of a tendency to think that it's more of a motility. Let's just kind of get the fluid motion of it. And then, so the kind of the elephant in the room is a lot of people have a lot of biochemical imbalances within that system, right? So that's why a lot of it will be motility based to me, because I'll address it also within the first visit, like, because I can have you taste gluten and have a Chapman reflex reappear instantaneously, as long as you're tasting it on your tongue. So it gives me a screening point to go, okay, so you have something going on with your colon and with your brain. The reason is you have a gluten sensitivity, which is causing leaky gut or some sort of a, you know, and I use sensitivity because, just so I'm being perfectly clear, I don't use intolerance. When I explain to people, I say it's an adverse food reaction, because that's what it is. I have no clue what the immunoglobulins involved are, but I can go, okay, you have gluten, and then I can use gluten and find something that will fix the gluten intolerance on top of it. So having people taste different stuff. So I do tend to do all that kind of in one visit. Anything else? So yeah, if you guys want to practice, you can practice, or else we can all go home and we can play with this another time. So it's worth kind of, so here, look, JC, I'll show you guys how quickly this can go, right? Just put your head over there, just so I don't have to change sides. So bicipital groove, eyes and ears, coracoid process, brain, sinuses, first intercostal space, parathyroid, thyroid, heart, lung, thymus on the right, fifth intercostal space, liver, fifth and sixth intercostal space, liver, gallbladder, sixth intercostal space on the left, stomach, seventh, pancreas. So seventh is pancreas, posterior, adrenal at T11, T12, belly button, 1 inch lateral, 1 inch superior, kidneys, adrenals an inch above, small intestine along the costal margin, symphysis pubis, urogenitary system. I'll go very medial and then a little bit lateral to the symphysis pubis, and then lateral kind of IT band, and then medially. So I mean, for the amount of time that takes, the amount of information I get back from it, I just do it every patient, every visit. And patients get that explained to them at the first visit. Like that whole first visit lasts a certain amount of time, just in order for me to be able to explain all this, so I don't have to do it ever again. And then they go, okay, this is what Sean does. He's weird, but that's fine. Like, that's just the way it works. Okay. There you go. Thank you very much. Which kind of fits?
Like everyone can have a different response. Like I was flexing my hand, but
Everyone's gonna have a different response, but their response to the same stimulation will be the same until it's fixed. So if he responds with lateral flexion and curling of the toes on the right, it'll always be that same response until that Chapman reflex is fixed. Thank you very much. Have a wonderful evening. I think you turn the recording off, and then if anybody wants to practice, we can practice, and then that's pretty much it. Arrivederci.